to our disclosures in regards to this. Due to the work that I have done on postural fractures, I was invited to be part of a design committee for the Volition ankle fracture system with all the solutions, and I'm also a consultant for Stryker and Johnson & Johnson. For further content, please also see our Liverpool Foot and Ankle channel. I've got many talks on this subject there, including approaches and different fixation strategies. So what do we know? So first of all, the historic results were poor. Two systematic reviews in literature prior to 2017 both reported poor results in postural fractures overall, and also both noted that importance of articular step in the overall result. The other thing is that postural fractures at this point was grouped under the same umbrella, but we came to know that these are very different injuries with different mechanisms. And this is our paper back in 2017 that showed that these were different mechanisms where you had a PITFL avulsion, which were type 1s. The type 2s were rotational pilons because the talus rotated within the mortise as the mortise was sat with the talus directly underneath, and as it rotated, it hit the posterior malleolar with overhang, and then if it continued to rotate, a major type 2B occurred, and type 3 were your typical axial loaded pilons. These mechanisms are shown in animations on the YouTube channel if you have more interest. So the other classifications, the Haraguchi was the first back in 2006. However, the use of this has become a lot less over the last few years. And the main reason for that is a difficulty in ascertaining what a type 3 was in the type 1. And many papers that have included this have mistaken these as big fragments and small fragments of the same with different mechanisms. The Botonisek was developed independently of us and has the same categories, apart from the type 2 and 3 were grouped separately, but we feel these are rotational pilons that should be grouped together. CT is required to know the injury. So this is now borne out throughout the literature. These are 9 papers, but it's up to 11 now, showing that CT is required to understand the injury. In one paper, they commented that there was a 22% diagnostic accuracy. And the reason for this is especially the posterior medial fragment hides around the back. So for example, this is a fracture you can see. Looks like a large chunk, but actually is a type 1. This one doesn't look too dissimilar to the last one, but we've got two fragments, a posterior medial and posterior lateral. And this one, again, doesn't look too dissimilar to the first two. We've got a large fragment at the back there. So to further understand these, you really do need to have a CT scan. This one, as you can see, not too dissimilar, and again, a very different fracture pattern to the other ones. Percentage of joint has no correlation to outcome. There's a lot of work has now shown this. If you classify it just on lateral radiographs, which was the initial paper back in 1940s in the Journal of Obstetrics and Gynecology, they found that with a very historic paper, that if you use the lateral radiograph, if it's greater than 25%, they've done well. If it's less than 25%, they've done worse. But as you can see, that we're now finding that these are very different mechanisms. And the two systematic reviews I referred to earlier shows that they both note the importance of articular step and size was not a factor in outcomes. A recent paper that's been submitted from Mandeep's group, I thought that I was involved with, has shown that morphology with functional outcomes is by far the most important factor. As you can see by this longer study, follow-up was almost 6 years, reduction was key and articular step off was the independent indicator and not size of fragment. And this paper by Blom, published in the last 2 years, shows that fragment morphology and not fragment size to take the functional outcome. So we need to discard this percentage theory now. It has been borne out in the literature that it's not true. So not all PM fractures have syndesmotic injuries, but PM fixations help stabilize the syndesmosis. So there's 5 papers indicating the reduced need for syndesmotic stabilization with fixation of posterior malleolar fractures. However, number one, not all have syndesmotic injury. Number two, if you do have syndesmotic injury, doesn't mean you can fix the entire syndesmotic instability with just fixation. So if it's just posterior, you can do it. But if it's a full syndesmotic injury, just fixing the posterior aspect does not confirm stability. And I'll give you an example of that now. So here we go. Some PM fractures don't have syndesmotic instability. We were asked why this was after our first paper. We returned to anatomy labs and showed that the PITFL is not only this small structure here that attaches to the Volkmann's fragment, but actually has this very, very large superficial component. So if you have a rotational pilon, such as this, the average size is a lot smaller than the average size of PITFL. So rotational pilons don't necessarily give you syndesmotic instability. However, some PM fractures have persistent instability after PM fixation. So for example, we have here a small fragment and a diastasis with 3 ligament injury. This was fixed by one of my colleagues, and they felt at the time that they didn't require syndesmotic stabilization. But you can see on weight-bearing views now, we have significant widening. On the CT scan, he's not weight-bearing CT, but as comparison to the other side, you can see a space. And the reason for this is that even though the posterior aspect has been fixed beautifully, the anterior ligaments have not been addressed, and that's why you've got persistent instability. This has been shown in a paper this year, a great paper showing with higher ankle fractures, so Mays nerve type injuries, Weber C fractures, where you have complete ligamentous loss, that if you have fixed the posterior mal, it doesn't confer stability. So you can see that here that they've just fixed the postural mal, and we still have diastasis and instability compared to postural mal and syndesmotic stabilization. Next one is more than one approach is needed. So when we first started this, posterior malleolar fractures were fixed just through the posterolateral aspect. And we found, so this is a paper of ours, CT-guided incision analysis, which showed that when you looked at on a clock face where the fracture patterns occur, where you want your initial screw fixation, then we're looking at when you get the type 2Bs and type 3s, there's much more likely to get through the posteromedial aspect than the posterolateral. And this is just a schematic of that. As you can see, when you get down to the type 2Bs and type 3s, the medial posteromedial approach becomes a lot easier to use than would be a posterolateral approach. We further took this to the CAD labs and showed that the posteromedial and medial posteromedial had a larger surface area of tibia exposed when used. And if you compare that to the size of the fragments, you can see the type 3 is a lot bigger than what could be approached to the posterolateral aspect. Next, fragment-specific fixation has improved the outcomes. So there's currently no randomized control study showing this, but our initial algorithm from our unit, which showed that you approach these through different incisions with fragment-specific fixation for 2As, 2Bs, and 3s, showed that our functional outcome from our initial paper back in a few years previously in 2018, that our initial OMAS scores for all posteromedial fractures not fixed with fragment fixation were very poor. And this was brought up to what would be bimalleolar expected levels with fixation. And this was across the board. So using this algorithm showed that you maintained a good functional outcome if you used these fragment-specific fixation. But we're not alone. There's many papers been coming out over the last few years showing that fragment-specific fixation, level 2 to 4 studies, show a significant improvement in outcomes. Direct approach is superior to indirect approach. So there's 3 papers on this. Level 1, 2, and 4 studies show significant improvement in anatomical reduction and functional outcomes with a direct approach. What I mean by a direct approach is approaching the posteromedial fracture directly rather than trying to fix it from the front or just fixing the syndesmosis. And the reason for that, you've got soft tissue entrapment. This is a great example of a tibialis posterior within the fracture plane. This is not the same patient, but a patient that came to us from another country which had been fixed. And you can see that they have, when they fix the fracture, we have tib post impingement, and as that's gone along, the tib post and then formed its own intraosseous tunnel. But what's left unanswered? So what do we know about the die punch fragment? So this is our paper back in, well, we published in the JBJS Open. When we take these 50 patients and put them as die punch and non-die punch, we see that there's still a significant difference between these. There's another 2 papers that have also shown this over the last 2 years. But what's the problem solving this? We can't see the joint, we can't see the incision, and radiology has limited use. So to look at this more from the peel-on aspect, if we do have a die punch in the middle, then what we're looking for is ways in. And mostly this is through the medial posterior medial approach to get into the fracture plane to get to it, or through the fibula itself. So to give you an example of this, we can see here we have a die punch fragment in the posterior aspect. On the CT scan, we can see that this is the die punch here, and we have a way in through the medial posterior medial approach. This is, as you can see, the die punch being further illustrated on the CT scan. So this is the medial posterior medial approach. Again, this is further described on the YouTube channel. But we can get in, this is your fracture plane. You can elevate this up and get this die punch fragment very easily. This is what's been done. We can see the die punch now has been restored with this. This is another example. The difference with this is that if you're achieving through this die punch fragment is much more lateral in its nature. So the fracture plane through the fibula is much easier to get to at this stage. This is from a paper on the transfibular approach, because you can actually rotate the fibula out completely. But we're not doing this in this case, in that we have a fracture plane. We can use the osteotome to bring this down and then to be fixed normally from the back. Okay, and that's where I will leave. If you want any more information, then please see the YouTube channel, as I go into much more detail about fixation and approaches.